slow. So this is my advanced patient care review. I did my critical care rotation at the VA with Dr. Lisa Maria. My name is Maddie. Okay. Oh. So as far as patient information, my patient was a 73-year-old white male who was admitted on November 3rd. He originally came into the ER complaining of low back pain related to some sort of mechanical lifting accident injury. I think he was helping somebody move. So when I was reading up on this patient, he had discharge plans in and he was expected to just go home. But it was noted that he had missed one of his dialysis treatments. So he was sent over to the dialysis unit at the VA. And during his treatment, he had worsening shortness of breath. And very soon after, he was non-responsive and rapid response was called. And he was immediately intubated. So at this point, he was admitted to the ICU. His primary admitting diagnosis was hypercarbic respiratory failure, and his secondary admitting diagnosis was hypotension and hypovolemic shock. So acute hypercarbic respiratory failure, in order to understand what that means, you have to know what the primary function of the lungs are, and that is gas exchange, so the elimination of CO2 and the delivery of oxygen to the tissues. So when either of those are impaired, it results in respiratory failure. And hypercarbic respiratory failure specifically is when you have an extreme elevation of CO2 in the blood and a subsequent decrease in oxygen. So this was my patient's CO2 levels. He was reaching 92, whereas the normal range is 22 to 32. Causes of hypercarbic respiratory failure include COPD, asthma, injury to the spinal cord, brain, ribs, or chest, acute respiratory distress syndrome like pneumonia, pancreatitis, sepsis, stroke, and infections. And then signs and symptoms include rapid breathing, inability to breathe, shallow breathing, sweating, fatigue, confusion, or arrhythmias. As far as nutrition implications go, just due to the fact that he has this inability to really breathe, he has an increased metabolic demand, so his estimated needs kind of are going to go up. And this can increase the risk of becoming malnourished. So at this point, it's a pretty good idea to implement nutrition support, especially if the patient is NPO or intubated and at a higher risk for malnutrition. So treatment for hypercarbic respiratory failure, pain medication as needed. If the patient has mild hypoxia and they're able to breathe on their own, then they may just be hooked up to an oxygen tank. But if they are severely hypoxic and become non-responsive, like my patient was, then they'll most likely be intubated. And two common ways of being intubated is a nasogastric, or more of a long-term would be getting that tracheostomy. So that's what this looks like. I thought it was a pretty cool picture. All right, so as far as the patient's past medical history, he has a thoracic aortic aneurysm, CHF, CAD, peripheral vascular disease, COPD, squamous cell carcinoma, end-stage renal disease, prostate cancer, cholelithiasis, iron deficiency anemia, and thrombocytopenia. And his surgical history, which I'm putting in here because I'm going to be talking about one of these surgeries he's had. So in 2013, he had an angioplasty with a stent to the left anterior descending artery. And in 2016, he had an endovascular stent graft placed. This is a minimally invasive procedure. that's used to treat the thoracic aortic aneurysm. And then in 2017, he had a drug-eluting stent placed, and then on an unknown date, he had a wedge resection in regards to his skin cancer. As far as the psych assessment, he was calm. There really wasn't anything to note specifically in that. As far as family history goes, the only thing that there really was on this patient was just that his daughter was his healthcare proxy, and she was pretty involved. He was initially DNR, but during his incident in the dialysis unit, they contacted his daughter, and they ended up changing his code status to full code, so that's why he was intubated. So what is a thoracic aortic aneurysm? It refers to this expansion of a section of the aorta that slowly degenerates and weakens as the aneurysm grows bigger and bigger. So just as a reference, the aorta is the largest vessel in the heart, and it extends from your heart to your pelvis and branches out towards your legs. And as that aneurysm grows bigger and bigger, there's an increased risk for rupture, and therefore causing a worse situation like damage to the aortic wall and bleeding out and death. And then a little statistic that I found that I thought was interesting was that the thoracic aortic aneurysms are actually very rare, and only 6 to 10 per every 100,000 people do end up getting these. So I thought that was kind of a little fun tidbit. As far as treatment goes, you can have a more invasive surgery, but my patient went and had an endovascular aneurysm repair, or an EVAR, which, like I said, was a minimally invasive surgery to treat the aortic aneurysm. And the procedure involves getting these 2 small incisions on your inner thighs near the groin area. And the surgeon will use these delivery catheters and insert them into the incision through the iliac vessel. They'll use an X-ray to be able to guide towards the aneurysm, and then they'll place this fabric-covered stent graft where the aneurysm is, and they'll remove the catheters. And I'm not a surgeon, so I don't know exactly how, but some way this stent graft sort of just goes into place like this and makes like this what the aorta would originally be like, and prevents blood flow from going into the aneurysm and therefore getting bigger. But complications of this EVAR procedure is an endovascular leak, or an endo leak. This affects about 15 to 25% of people who've had this procedure. So this is what it normally will look like. But an endo leak would be blood leaking back into the aneurysm sac and increasing that risk of rupture. There are 5 different types. Type 1 and type 2 are the most common. I'm not going to go through all the 5 types. And I also am not positive what type my patient did end up having. But treatment is required for any type. And some types are more life-threatening than others. And this is diagnosed with a CT scan. So I want to mention that during his CT, he did get a CT scan, and they did see that there was some sort of fluid collection of some sort surrounding his aneurysm. So that's why they sort of claimed it to be an endo leak of some sort. Causes of this include some sort of gap between the graft and the aorta wall that, allows blood flow inside. If there's increased pressure within the side branches of the aorta, this forces blood to leak back inside. If there's any sort of defects in the graft, or endotension is another cause, which I'm not really going to go into either, but it's a poorly understood phenomenon. As far as symptoms go, patients don't usually exhibit any symptoms. For the most part, they're asymptomatic, but some may complain of abdominal pain or back pain, which my patient did complain of both. I don't know if they are directly correlated to this or not. So for his plan of care, they wanted to, they inserted a central line for fluid replacement due to his hypovolemic shock. They also placed an arterial line just to monitor his hemodynamics. He started on vasopressors because he was hypotensive. And then they also monitored the central venous pressure in the vena cava. And what that means is they wanted to see the amount of blood that's returning to the heart and the ability to pump blood back into the arterial system. They didn't end up doing this, but a platelet transfusion was recommended if there was blood loss, like severe blood loss noted on the CT scan. And then additionally, they had a repeat CT scan, and they consulted vascular and renal to follow any sort of EVAR protocol for leaking. And in order to follow what the protocol is, they needed to determine the type of the endo leak. So as far as the nutrition assessment goes, he was suspected for COVID, so he was placed in a negative pressure room, and I wasn't directly able to visit this patient. He was also intubated, so he wasn't really able to speak in general. So no nutrition history was really collected on this patient. He was really critically ill, so I don't even think it would be appropriate at that time anyway. And therefore, no nutrition focused physical exam was done. As far as his physical exam, I got this based off of the resident note. And something interesting too is at the VA with Dr. Maria, she had us go in and do rounds every day with the ICU team, which was like 4 hours a day so that's where I got the basis of my information about the patient, which was like way more than I probably could even understand. So, like I said, patient was not really had any difficulty breathing at the time. He was connected to the vent. He didn't appear in any acute distress. He didn't have a distended abdomen. His bowel sounds were present. So that meant that his GI function was properly working. So enteral nutrition was a go. Bilateral lower extremities were cool to the touch, which was something they really talked about. And I didn't really know why. He was sedated as well. And like I said, he did have some abdominal pain. This patient was 5'11", 157 pounds. This was taken on November 3rd, so the day he was admitted. His last weight was 152. This was taken on September 2nd, and he really didn't have any significant weight change, but I think it's important to note that he has end-stage renal disease, and he gets hemodialysis 3 times a week. So fluid shifts are very common. In fact, you want to see fluid gain in between dialysis treatments. So this is pretty normal. His ideal body weight is 172. His percent ideal body weight is 91%, and his BMI is 21.9. Additional information, he did have a stage 1 pressure injury to the sacrum and coccyx. As far as hydration, his electrolytes were abnormal, but he does have end-stage renal disease, so that's pretty common. There was no edema noted and no jugular vein distension, and that's the vein in your neck here, and they look at that to determine dehydration. If it's like bulging, it could indicate that they're dehydrated. And he did receive IV fluids in the ED as well as in the ICU. And he doesn't have any amputations, and that's something that at the VA they always record because it's very common for the veterans that come in to have amputations. So for lab values, his glucose was high if you're looking at normal reference ranges, but in critically ill patients, glucose reference ranges are actually higher. So he's actually within normal limits there. So there's no concerns, and he also doesn't have a history of diabetes. So there's nothing really, it's not really actually high. His BUN and creat are high, but he has end-stage renal disease. So there's no correcting those at that point. His GFR is also low. Sodium, his electrolytes, so sodium was low, phosphorus was high, and his potassium is high as well if you're looking at the normal reference ranges, but during my renal rotation and for the new Kadoki CKD 2020 guidelines, the reference ranges for potassium and phosphorus are actually shifted higher for end-stage renal disease patients on hemodialysis because they're just commonly high. So you're not really going to see a lower reference or a lower range within the normal range. So it's about 3.5 to 5.5. As far as medications, he was on a couple meds, but none of them really had any food and drug interactions. The only nutritionally relevant medication is his pantoprazole, which is the proton pump inhibitor, just used to treat GERD or acid reflux. So I don't really have anything more to add about medications. For his needs, I calculated his needs out to be 1,785 and 2,150 kcals per day. This was based on 25 to 30 kcals per kilogram. I chose this equation to do instead of the Penn State equation, even though that's a common practice for vented patients, according to the Aspen guidelines. I wasn't able to go into this patient's room to look at his monitor to view the minute ventilation, which you need to calculate the equation. So I didn't end up using the Penn State equation, but I did use it for other patients. And it is a pretty big difference between the Penn State equation and like the 25 to 30 kcals. So you kind of have to use your clinical judgment there. And if they really need like 3,000 calories or not in that critically ill state. For protein, I did 86 to 107 grams per day. This was based on 1.2 to 1.5 grams per kilogram. He has increased protein needs related to him receiving dialysis 3 times a week. They lose protein during that treatment. He also is in a critically ill state, and he does have a pressure injury. So his protein needs are going to be higher, but I went more towards the modest side of it because technically you could go up to 2.5 grams per kilogram, but I didn't want to go that high. And then for fluids, for end-stage renal disease patients, this is really up to the med team, but common like practice under the Kadoki guidelines is 1 liter plus daily urine output, which usually at that point, those patients don't really have a lot of, they're not producing a lot of urine. I was able to come up with 3 PES statements. So inadequate oral intake related to NPO status as evidenced by needs for nutrition support via NG tube. Increased nutrition needs, calories, and protein related to hypercarbic respiratory failure and end-stage renal disease with hemodialysis as evidenced by chart review and plan of care discussion. And then lastly, altered nutrition-related lab values related to end-stage renal disease as evidenced by increased BUN, increased creat, low GFR, low sodium, increased potassium, and increased phosphorus. So for my nutrition intervention, we recommended enteral nutrition. We decided on doing Nepro. So to initiate Nepro at 10 mLs per hour and increase by 10 mLs as tolerated towards the goal rate of 50 with additional 30 mLs of water flushes every 4 hours. This would provide 1,200 mLs total volume, 2,160 kcals, 97 grams, and 886 mLs of free water. Our goals for this patient were obviously to initiate the trickle feeds and hope that he tolerates and to increase towards his goal rate with no sort of toleration issues. As far as weight goes, it's common to see fluid shifts in the ICU, so we don't really need, it's not necessary to like monitor his weight really strictly, but we want to make sure that he's at least like maintaining lean body mass and he's not losing a ton of weight. As far as electrolytes go, we want them to be within normal limits and glucose to kind of be within normal limits as far as in a critically ill state, between 140 and 180. GI, just promote normal bowel function, no GI upset, and then promote wound healing of the stage 1 pressure injury, specifically making sure it's not getting any worse. Nutrition education was deferred at this time. He was intubated and in a negative pressure room. So for nutrition monitoring, we want to monitor his tube feed toleration. So specifically looking at signs and symptoms of like abdominal distension, cramping, tenderness, nausea, vomiting, constipation, or diarrhea. Monitor his tube feed rates to make sure that he's reaching his goal rate and he's reaching his estimated needs, because he does have an increased risk of malnutrition. So it's important to look, because nurses and other people will constantly like stop the pumps and everything. So just making sure he's reaching his goal rate, and then monitoring his daily labs and adjusting tube feed formula rate, whatever as needed. As far as evaluation goes, the patient did start on trickle feeds and he didn't have any toleration issues. I specifically wasn't able to see this patient for a follow-up. We did our critical care split up in 2 sections, and I saw this patient my last week of clinical in general. So I wasn't able to follow up with this patient specifically. But I did print out like his follow-up as far as what the residents and the ICU team did. So I know that he started on the BiPAP machine but had no improvement. But after his intubation, his mental status and his oxygen status was improved. His CO2 levels did decrease from 92 down to 20, and 20 actually is a little bit low, but that's better than 92. Radiology reviewed the patient and his aneurysm had grown larger. So vascular surgery was following as far as what they were going to do next. And he was still receiving hemodialysis, but they did not remove any fluid because of his hypovolemia. And he was on vasopressor support to ensure that his blood pressure didn't drop too much. And that is all my sources. Like I said, I wasn't able to follow up with this patient exactly. So does anybody have any questions?
So I have a question. I want to go back a little bit earlier. Can you clarify why you didn't do the nutrition focused physical exam? Because it sounded like because he was in the ICU and medically complex, he didn't need one. Can you refresh me on that?
Yeah, so they suspected him for COVID. So he was in a negative pressure room and nobody was allowed to go in the room except for like the residents and the nursing staff. So I wasn't able to go into the room to see the patient. He was in like a specific room. And but I did like peek my head in, and he didn't appear like malnourished. He was potentially at risk for malnutrition.
Okay, I missed that COVID bit because all I heard was he was in the ICU, so I didn't do an exam.
Oh, no.
So I'm just making sure that I understood correctly.
Yeah, they had concerns for COVID. Yeah.
Mm-hmm. Okay. So what makes you think that he was at increased risk for malnutrition if you don't have a baseline?
So basically, he has like increased needs, metabolic demands, just based off of like his critical state. And he wasn't getting like any food, or he wasn't eating, he was NPO, and he didn't have his NG tube placed. So he was just like at risk for becoming if something wasn't happening.
And how long was he like that?
Since he was admitted, so a few days.
I missed the first like 5 minutes.
Okay.
So I'm just asking. So he wasn't that way for very long, or it was 7 days, or?
No, it wasn't very long. It was just we wanted to make sure he was getting his nutrition, essentially.
All right. Thank you.
Mm-hmm.